just thought this was an odd term. State of confinement. Just sounds like you'll be incarcerated. But that's basically the delivery date. No method is really exact, but there are a couple different ones. The one I want you to know that will require some calculation is Nägele's rule, and we'll go through that. But also fundal height and quickening can be utilized, as well as the heartbeat. So basically, you subtract 3 months from the first day of the last menstrual period, and then add 7 days. A weird way to go about doing it. So, if your first day of your last menstrual period was March 25th, subtract 3 months will bring us back to 12/25. Add 7 days, be January 1st. So that's your due date at that point in time. Okay. So subtract 3 months, add 7 days. Anticipate a question of that nature on Wednesday. Okay. Fundus, you can look at the fundus of the uterus, which is obviously the top of the uterus, the opposite end of the cervix, or from the cervix. And you can kind of measure as the uterus grows outward because of the presence of the fetus. It's not reliable during the last trimester, but by that point in time, it's kind of, you should really have an idea by that point. But basically, if you measure from the symphysis pubis to the top of the fundus, it's roughly 1 centimeter per week gestation. They palpate. I don't.
I didn't know if it was an image.
I want nothing to do with that. No, usually just manual palpation, although sonography could be used. That's right.
So 1 centimeter was 1 week?
Yeah, roughly.
Okay.
Quickening is basically the first sensation of fetal movement experienced by the mother, and it's roughly about 20 weeks, anywhere in the range of 16 to 22. Again, very rough estimation of gestational age at that point, or fetal age, I should say. And then the fetal heart rate is almost always heard by 20 weeks, but can be heard as early as 16, and with high-tech devices like we utilize now, even earlier. Again, kind of gives you a ballpark figure, but Nägele's rule is the one that we typically end up using for determining the confinement. Meconium, if you remember, is a thick, dark greenish stool that's found inside the fetal intestine. And normally the passage of that meconium occurs in post-term infants, in 40% of them, when you start having gestation taking longer than the 40 weeks we normally would have. Can also occur during due to asphyxia, and this is really the key part that we end up seeing. If you think about it, they're so stressed that they just expel the meconium into the amniotic fluid. The problem comes is that after birth, or during the birthing process, if that meconium gets into the airways, it can lead to what we call meconium aspiration syndrome, which is not a good thing. You know, when we get to neonatal diseases, we'll come back and visit this, but it is a problem because that obstructive element that is there, meconium is like thick, tarry stool, and it can actually cause airway obstruction to the point that air can get into the lungs but can't get back out. And that basically is what we call a ball valve effect, that it basically, as the airway, remember on inspiration, the airway becomes wider, air can get through, but then it closes back off on exhalation. You end up with this big trapped gas and potential for pulmonary barrel trauma. Maternal history, there's 2 terms you should be aware of. Gravida is the number of pregnancies, including those pregnancies that did not make it to a live birth. We call a primigravida, first pregnancy, or multigravida, having more than one. Parity, on the other hand, is the number of live born that were delivered past 20 weeks. So it doesn't really talk about what the condition of the child is. It's basically that a pregnancy went more than half of the gestational age at that point in time. Other options that you have are either a spontaneous abortion, what we would call a miscarriage, or a therapeutic abortion. So there's some examples there. Gravida 1, para 0 would be a no, it's a mom who's pregnant but hasn't delivered yet. So we're still waiting for that delivery to happen. Could also be a spontaneous abortion, yes. Or, although usually in that case they would list the number of spontaneous abortions that we have in the fifth one. Not if it's before, yeah, it would have to be before 20 weeks, or after 20 weeks, yeah. Gravida 1, para 2.
One pregnancy, one birth.
1 pregnancy, 2 births. Twins.
1 or 2, you said?
Para 2.
Oh, you said 2, I'm sorry.
Yeah, and gravida 1, para 3, triplets. You get the idea. So, parturition is that process of giving birth. It's a fancy name for it. And there's 5 events that ends up happening. There's a rupture of some membranes, the dilation of the cervix, contraction of the uterus, and then the shrinking, the separation of the placenta, and the delivery of the placenta, and the shrinking back of the uterus. Kind of different phases that they go through. Labor specifically has 3 stages, 3 distinct process. First of all, there's the onset of contractions that occur through the early phase, and then through the active phase, there's dilation and effacement of the cervix, and finally a transition through which stage 2 happens, where the delivery of the fetus, and then finally stage 3 delivery of the placenta, and then there's a recovery phase, as we said, where the uterus shrinks back to normal shape and size, and there's a homeostasis that remains after that point in time. False labor or false contractions that aren't associated with active labor are called Braxton-Hicks contractions, and they're rhythmic and, I'm told, fairly mild compared to the true contractions that exist for delivery. Again, I'm not speaking from personal knowledge here. Stage 1, we talked about having that effacement and dilation, beginning with the first contraction. Effacement is basically where the cervix stretches and thins, and the dilation is the widening of the cervix that you want to end up having. We measure effacement as a percentage, with 100% effacement meaning that the cervix is imperceptible, indistinguishable from the uterine wall. And dilation is measured in centimeters, with full dilation being 10 centimeters. So we'll say mom is 4 and 40%, or 5 and 60%, whatever. Meaning, how far along labor has progressed. Effacement and dilation. Then stage 2, we deliver the fetus, where the uterus, that thick muscular upper portion, contracts and it pushes the fetus down the birth canal. And abdominal diaphragm muscles also are utilized to help generate the intrathoracic pressure necessary to push down on that uterus. Majority of the time, as we mentioned last time, the deliveries are in the vertex position, and the head actually turns to a face down rather than a face up when it's coming through the birth canal. And then finally the umbilical cord is clamped, and within a short amount of time the placenta is delivered as it separates from the uterine wall, and the breastfeeding is associated with the release of a hormone called oxytocin, which basically increase uterine contractions and try to get everything completed. There's a neat little video. Let me go ahead and I'm going to show it on my other screen here. And here you can see the effacement and dilation happening. The big ouch. And once the head is out, it rotates back. And then once the shoulders are out, it's pretty much rustles out pretty easily. I like that. Drives it home pretty well. As far as the dilation and effacement. All right, Preterm labor is an important thing. It happens in 40% of high-risk patients. They end up having labor starting prior to, and because of that, we end up having preterm delivery. Some of the risk factors for that preterm delivery, again, having a prior preterm baby makes the next one have a higher rate also. Premature rupture of the membranes can lead to a preterm delivery. Various infections of the mom or the fetus itself, multiple gestations or polyhydramnios will end up having a premature delivery. We talked about placenta previa and a placenta abrupto, both having the placenta abruption being the premature separation of the placenta from the uterine wall, and placenta previa being where the placenta is implanted lower and may lead to problems also. Uterine cavity abnormalities, fetal anomalies, and cervical insufficiency, meaning that mom doesn't have the cervix that is prepared enough for delivery, and that can lead to a preterm labor. 6 contractions in an hour associated with dilation and effacement is basically how we're describing labor. There's also some secretions of some fibronectin. You need to know that, but it's basically some material that is secreted that says, hey, I'm coming. What the attempt is to stop the labor, and the term for that is tocolysis. Once we've well-hydrated mom, we can give them a sympathomimetic drug, like terbutaline is the most common one utilized. Will basically stop the contractions of the uterus, suppress that, because the smooth wall in the uterine is very, very similar in structure to the smooth muscle that's in the airways. A drug like terbutaline can be utilized to relax that smooth muscle, suppress the contractions, and hopefully stop labor from happening. Can also give a drug, magnesium sulfate, for that purpose. And there is a prostaglandin inhibitor which could be given also in the methicillin. But usually terbutaline is the most common, or ritodrine would be the most common mechanism by which we suppress labor in contractions. Baby usually has to be between 20 and 37 weeks and in true labor, so that if the baby's older than 37, there's probably enough surfactant around to suffice extrauterine life, so it's not as big of a deal. If for whatever reason the cervix cannot be dilated more than 2 or face more than 80%, you don't want labor to continue, because that will not be very pleasant upon mom. If the amniotic membranes are still intact, you will want to try to suppress it. Once the membranes break, you're kind of locked into having that delivery happen. No signs of fetal distress would be indicated. If there is fetal distress present, that typically means that something's going wrong, and you need to typically do a C-section to be able to get the baby out, and obviously with informed consent. Contraindications, some absolute ones you can see there. Fetal compromise, you don't want to suppress labor, you want to get that child out of there. I'm trying to remember what IUGR is. I'm losing my mind here. Intrauterine growth retardation, I think. Could be wrong there.
Should we know all those for the test?
No. Give you an idea. Just that there are times where we don't want to have labor suppressed. The biggest one being fetal compromise. Anytime you got a baby that's in distress, you want to get it out of there as quickly as possible. Dystocia is the term that we use for difficult labor, where the stage 1 and stage 2 are taking longer than 20 hours. Or stage 2 itself is longer than 2 hours in a first-time delivery, or 1 hour in a multi-delivery. And as that length of labor increases, the morbidity, mortality of both the fetus and of mom goes up. For one, you can end up having that abruptio placenta happening. Can also have the umbilical cord being compressed, secondary to in a cervix that's not dilated enough, the cord starts to become compressed. And obviously, once that membrane ruptures, the biggest fear that we have is infection to the child.
So, with that, the stage 1 and stage 2 exceed 20 hours, is like the majority of that stage 1?
Probably yes.
Did you have to-
Yeah. Some of the causes, we talked about uterine dysfunction, whether it's not contracting appropriately, abnormal fetal presentation, we've talked about baby being breached, the baby being transverse lie, excessive fetal size, especially in diabetic mothers, they can end up having not only a delivery that's late in coming 42 weeks, but you end up having usually a larger than normal baby. Hydrocephalus we talked about, and if mom for whatever reason just doesn't have the birth canal developing or progressing in the appropriate fashion. Multiple gestations, just kind of give you some idea. 1 in 99 births are twins. A little higher rates in some other ethnicities and lower in some other ones. So other multiples are more rare, as you can see. There actually was a case, and I was actually working in Grand Rapids at this time, where they ended up having a sextuplets, 6 children, born on 3 different days, which is totally unique. One was born on January 7th, one was born on January 16th, and not one. I think there were, I'm going to get this wrong, I know. It was like 2, 1, and 3, born on different points in time.
In the U.S.?
Grand Rapids, DeVos Children's
Oh,
Hospital.
they missed their tax deduction by a week.
Yeah, yeah, the truth. Well, they were already born. I mean, the youngest ones were 23 weeks. The oldest ones were 25 weeks, so they needed that extra week in the oven.
The rule of thumb we had having the boys was that the last month of the pregnancy, the fetus gains a pound a week. Is that
I'll
true?
buy.
Is that-
I'll buy. Yeah.
Have you heard that?
I wouldn't dispute it. Sounds about right. But all 6 of them weighed 9 pounds 2 ounces total. So you can see that they were a little bit. They were little rugrats. Trying to find a news report that they did it as a follow-up to them on 2013 when they would have been 9 years old. And she actually had a single pregnancy, a single delivery after she had the 6. Now this is
Right, I mean, really?
and I can't get this to load, but unfortunately 2 of them had pretty severe brain injury and are wheelchair dependent and from a cognitive, they have a huge cognitive delay. Many of them have vision problems, so at any rate.
Now,
It won't
did they
load.
say if these were from fertility drugs or?
You know,
It does happen
I
naturally.
believe that this was
A natural
no
fertility.
of a fertility issue. But the interesting thing was, in the same neighborhood, there was someone else who had 5. So maybe it's in the water. I don't know. But obviously, multiple gestations are not only a problem for the children that are being delivered, but also at a higher risk to mom of having some complications secondary to pregnancy. And obviously, the more births you have, the higher chance you have of a premature labor happening. Interestingly, twin B is always worse than twin A, and boys are always worse than girls.
You mean condition-wise?
Meaning that, yeah, condition-wise.
What if the boy comes out first?
typically then if the girl comes out second, the girl would probably have a little more of problems. Think about it. I mean, they're basically inside the uterus waiting to come out, and their cord can become compressed. They're, you know, all kind of other problems can happen. Again, we talked about postterm pregnancy, where it's longer than the 40 weeks that we kind of use as our mark. Many times just because we can't adequately predict what the expected date of confinement is. They may require cesarean delivery through the size of the baby, what we call macrosomia, meaning that they're very large, too large for mom to deliver. They're also at a risk of meconium aspiration, as we say, because the bowel is starting to work. And they also can have some problems where the placenta isn't adequately able to supply nutrition because of the size of the child. And we can induce labor on these kids by using that oxytocin is the drug. And there's a little guy coming out. What can you say? Once they're delivered, then they get this rude awakening where they're in this nice, warm, wet environment, quiet. All of a sudden come out and it's real bright and cold and ugly.
Put me back in.
Put me back in, that's right. Did I ever tell you that joke?
What was the movie, Look Who's Talking?
Okay, so we see fetal breathing movements actually occurring in utero. The diaphragm basically trying to get its function under place. Usually you'll end up seeing within the last 10 weeks. Multiple reasons why that first breath occurs. Obviously in utero it can be due to asphyxia. When we talk next time after the exam, we'll talk about primary and secondary asphyxia that ends up happening. But remember, asphyxia is that combination of a low PaO2, high CO2, and low pH. Those things that can trigger the chemoreceptors to stimulate a breath, or a gasp at the very least. Usually it's the recoil of thorax that occurs when it's coming down the birth canal. The thorax is squeezed, and once it responds back again, it triggers a breath to end up occurring. And we talked about the initiation of the cry reflex because they're in this awful environment. And any tactile stimulation that we would do as far as drying off the baby, that would stimulate a breath also. The first breath is generated with an extremely high pressure. That after that point in time, and after you establish the FRC, the pressure can decrease because I now already have air filled into that area. As the alveoli deflate, that surfactant being present prevents them from complete collapse. And every breath that goes on requires less and less energy. This is out of Egan. You can see that the first breath requires a huge amount of pressure. And once you got that volume established, you establish your FRC, less and less pressure is required. But that first breath can be quite profound. At the same time as that breath occurs, and air is now inflating the alveoli, which were previously filled with fluid, you end up having the umbilical cord being clamped, and that low vascular resistance system now becomes high as the blood flow to the placenta is stopped, and the blood flow has to go to the lower extremities and the rest of the body. That high vascular resistance develops, and the high pressures within that circuitry cause the left side of the heart to become higher than the right side of the heart, so now the foraminal valve closes. That's the important thing to remember, is that the foraminal valve closes, secondary clamping of the umbilical cord, and pressures within the left side of the heart becoming higher. That first breath also decreases the pulmonary vascular resistance because the PaO2 rises. As PaO2 rises, pulmonary vascular resistance falls. Remember, one of the most potent vasoconstrictors in the pulmonary system is hypoxia. So as that hypoxia is relieved, because now I have air filling the lungs, the PVR falls, and that leading the pulmonary artery then, pressure goes down, right side of the heart goes down, and you end up basically having the reversal of the heart pressures and vascular resistance that we had previously, and that's one of the things that promotes the ductus arteriosus to close. During the last few weeks of gestation, the smooth muscle around the ductus arteriosus begins to constrict, and it actually becomes a ligament as opposed to being, eventually becomes a ligament as a vestige of what was there previously as a vessel. The ductus has stayed open due to the presence of prostaglandins. What ends up happening is when the PaO2 rises, prostaglandin levels fall. The falling of the prostaglandins cause the ductus to begin closing at that point. So where the foraminal valve is due to pressure differentials, the ductus arteriosus is secondary to hypoxia being relieved, PaO2 rising, and that stays open. If the PaO2 should subsequently fall, we end up having a situation where the pulmonary vascular resistance rises again, and that ductus remains back open again. We call that a patent ductus arteriosus, or a PDA. It's one of the processes that some of the diseases we'll talk about, because of the profound hypoxemia, they end up going back into fetal circulation. We used to call it persistent fetal circulation. We now call it persistent pulmonary hypertension of the newborn. Bottom line is that that PDA remains back open again.
How long is that window usually between, like, how long does the baby have?
Usually it begins closing actually prior to delivery, but remains open until usually 2 to 3 days after birth. And it finally, if ever the PO2 is okay, remains closed. However, it can remain open for a prolonged period of time in some of these diseases, which leads to huge problems. Because then I have a huge amount of shunting, making the PO2 worse, and it's just a cyclical pattern where they end up having the persistent hypertension in the pulmonary system. Sometimes, and I think I might have mentioned this, there are a few cardiac defects that we'll have that if you didn't have a PDA remaining, you wouldn't be able to sustain life. So there's some of these where we purposely create hypoxemia, delivering to the baby 15 to 17% oxygen, causing the PaO2 to be drastically low, and trying to keep that PDA, trying to keep that ductus arteriosus patent.
So what could be the cause of low PaO2?
Surfactant deficiency.
How about cord compression?
Usually this is after birth, so you're not seeing the cord being involved. That would probably lead to neonatal asphyxia. There can be things that can be associated with problems like meconium aspiration secondary to that, which can lead to this. But there's a lot of things that will cause a ductus to stay open. But anytime the baby is hypoxemic post-delivery and the PO2 isn't rising, the chances of the ductus arteriosus staying open goes up. So, PaO2. Ductus venosus, should be venosus, shouldn't it? Should be an S in there. Yeah, ductus venosus. But basically when the umbilical cord is clamped, blood's no longer flowing through the umbilical vein. And those vessels themselves will begin the constriction and eventually become ligaments. What we can do is cannulate the umbilical artery, run a cannula back up into the descending aorta, and be able to utilize that as a blood sampling and blood pressure monitoring site. We'll talk about that another day. But again, your ductus venosus bypassing the liver, foraminal valve between the right and left atria, and the ductus arteriosus being between the aorta and the pulmonary artery. And Mike was asking earlier about the location of the PDA is variable, so it can be as high as here and as low as here. So it's in that general area. That's why we consider the left arm variable, because it's getting some blood flow through from the PDA in the process. That's it. Okay. I'm done. Questions?
Yes.
How-
Both